Okay, so hi everybody, and welcome to the webinar. Next version of RSIP Virtual Bay Vision. Today our guest speaker will be Dr. Ester Bonmati from the WEISS Center at UCL, and she's going to talk about her cutting-edge technological research on EUS and how computer vision and tracking technologies and AI technologies can be used to enhance EUS. We have another special guest speaker who will also be saying a few words. We'll introduce him in a second as well. Just a few words about who we are. We are RSIP Vision. We provide AI and computer vision solutions for medical devices and applications. Our company has a strong multidisciplinary team, and we've been doing this for over 25 years, partnering with medtech industry leaders. Our solutions and software and modules are baked into medical devices that have been used in thousands of procedures and cases in the field all over the world. On the lower right of the screen, you can see one example of our work that's currently being integrated and being worked through the FDA processes by one of our clients. It involves detecting in ultrasound the proper acquisition of relevant anatomy. In this case, this is a TE for a cardiac application, and then measuring that relevant anatomy. And we're also currently involved in other related technologies, such as the ultrasound to MR fusion in different contexts, endoscopic video analysis, for gastro applications and for surgical video applications, 2D to 3D reconstruction for various anatomies such as the biliary tree. So if anybody here would like to chat about how RSIP Vision could help you, please feel free to drop me a line. My email is on the left of the screen you're looking at now. It's pretty simple. So again, our main lecturer of today will be Dr. Ester Bonmati, who will talk about her research and her insights from the technological side, and she's affiliated with UCL of London. Before that, we have another special guest speaker, Dr. Minimally-invasive, and we as RSIP Vision are quite hopeful about the potential for AI contributions to US. For various use cases, from democratizing this procedure and helping with physician training to 3D planning and navigation, and eventually also various advanced classification applications for subtle use cases. Before we get started, I'd like to invite Dr. Mizrahi, who is also a member of our clinical advisory board here at RSIP Vision. Dr. Mizrahi served as a professor at Hadassah School of Medicine, and he now serves as the Advanced Endoscopal Fellowship Program Director at Largo Florida Center for Gastroenterology. He performs advanced endoscopic procedures such as ERCP, EUS, third limb endoscopy, and more, publishing clinical papers and also mentoring the next generation of advanced endoscopists. Dr. Mizrahi, thanks for taking a few minutes of your time to share your unique clinical perspective. And I will pull up your slides in just a minute for this intro before we get to the main lecture. So just give me a couple minutes to pull up these slides and we can get started. Okay?
Sure.
Here we go.
So first of all, I can say thank you for the invitation, Moshe. And as endoscopic ultrasound for 24 hours easily and all the applications and what we can do with that. But since I already heard Dr. Bonmati presentation, I'm telling you, you're going to hear a great presentation with a great new things and new innovations. So I will take just 2 seconds of your time talking about things that I see as a combination of endoscopic ultrasound and artificial intelligence, and where those worlds can engage and serve as a better, let's say, screening tool or interventional tool for our patients. So, okay, next slide. So, you know, we are talking about the future of endoscopic ultrasound and artificial intelligence. So before talking about the future, let's talk 1 second about the past, okay? So not so long time ago, like I would say 40 years ago, the first endoscopic ultrasound scope was developed. Initially, it was a 360 degrees a scope, what we call radial scope actually, and with no abilities to perform any biopsy or sampling. So it was just like an abdominal ultrasound for imaging. Then with time, of course, the quality of the images improved, and on top of it, we developed new types of endoscopic ultrasound, what we call the linear scopes, which are 180 degrees, more or less, depends which company you're using, scopes, and you get this view and have a working channel that you can actually use an FNA needle, fine needle aspiration, or fine needle biopsy to sample the lesions too. And from there is another level of endoscopic ultrasound, which is interventional EUS, which is, actually connecting different organs and different luminal organs or collections intra-abdominally in between with different types of stents. This is like much more complex endoscopic ultrasound abilities, and I'm sure AI at some point will have a lot to share even in the interventional endoscopy field. Next slide, please. So I would like to give you actually 2 examples of real-life cases that I think AI might be important and can give us additional information to improve our abilities. So for example, one of the things that I can talk about is planning for surgical treatment. And that's from real life, guys. That happened 2 weeks ago, actually. Patient, 66 years old man, was referred to us due to complaint of abdominal pain and CT scan that shows cystic lesion, fluid lesion within the pancreas. We performed an endoscopic ultrasound. We saw a mass component and not just fluid component. We biopsied this area. It came back as cancer. On the actual endoscopic ultrasound, we saw involvement of the splenic artery, but the celiac axis looked okay, and we couldn't get anything also from the CT scan as far as involvement of other organs like the spine or the aorta. And due to the risk of bleeding from the invasion of the cancer into the splenic artery, we took the patient to surgery. And yesterday he had his surgery, and unfortunately they called me to the OR to see, but the cancer actually involves also the aorta and the spine, abutting the spine, which makes it impossible for resection. Next slide, please. Not slide, just a line. Perfect. And due to this involvement, actually the surgery was canceled or terminated. And I think that with a combination maybe of different images like CT scan, MRI, or and endoscopic ultrasound and 3-dimensional reconstructions, maybe we can serve patients better as far as planning their surgeries, and even not just planning the surgery, but actually determine if a patient is a surgical candidate right now, right here, right now, or actually need better chemotherapy, neoadjuvant, prior to planning for a surgery. So that's something that I think AI can intervene in the world of endoscopic ultrasound. Another thing from real life that, just by thinking about it yesterday, those are 2 small applications that I think I can make you think about. For example, diagnostic yield. We all know that pancreatic cancers are more desmoplastic reaction and less viable cells of pancreatic cancer. And what happens a lot of times is that actually you do your biopsy, and you send the patient home, and guess what? The path can come back as non-diagnostic or no cancer. But the clinical story, the images, everything yells cancer. So you actually bring the patient back again to the endoscopic ultrasound, trying to take biopsies again, maybe having even an on-site pathologist that actually interpreted the specimens during the procedure, trying to give you a confirmation for the diagnosis. That's something that I think artificial intelligence can intervene into. We know based on the image and the consistency of the lesion, we can imagine where there are more viable cells and tissue that we can actually sample and target our needle towards this area. And I think if we will be able to teach the system how to recognize those areas and aim, or makes us aim those areas that most probably there we will get the actual diagnosis, that will increase by far our diagnostic yield. And next slide, please. I think just with that, I'm done, and I will give Dr. Bonmati the stage to give a presentation. But before that, just talking about things that, as I said, AI can help with. We all know about the training. We can do a better approach to physicians that are not fully trained in endoscopic ultrasound. A lot of GI physicians are actually afraid of doing it just because they feel confident on their skills of doing those procedures. And so delivery to different areas, and also physicians that didn't have the actual proper training, better planning of surgery, and increased diagnostic yield. And thank you very much.
Thanks so much. Yeah, thanks so much for this perspective, and we'll let you go run back to your patients, but really many different ways to attack this field, from the visual and geometrical and 3D context of things, and then later on, once we're able as a community to gather more data, also this fine-grained classification based on a lot of information into those AI systems. And I think we're going to hear from Esther many things about both of these cases, especially about scope tracking and about registration, which is useful in the surgical and the planning context, and a bit about the future and how AI can be used as well. And with that, I will make you the presenter. Esther, please go ahead.
Thank you. Yeah, sure. Right. Can you see my presentation now?
Yeah, I got it.
Perfect. So thanks for the introduction. It's been also really nice to see Dr. Mizrahi presentation, because I think we share a lot of common opinions here. So yeah, my name is Ester Bonmati. I'm a WEISS Senior Research Fellow at University College London. So I am at University College London. Something bothering me. Just one second. Yeah, okay. I hope you can still see my screen. And yeah, so more specifically, I'm in the Wellcome EPSRC Centre for Interventional and Surgical Sciences, which is a center that brings together engineers and clinicians to work on the development of new surgical technologies. My research interests are in medical devices, ultrasound, computer-assisted interventions, and also deep learning. And yeah, I'm a computer scientist, actually. And so this talk will be focused on endoscopic ultrasound interventions, or EOS, I will call it from now on, which is a minimally invasive technology that is used in procedures involving the gastrointestinal tract. And this procedure involves the insertion of a flexible device called endoscope that is inserted into the mouth and all the way down to the stomach and duodenum. It is used to get detailed ultrasound images of the organs that surround the stomach, such as the gallbladder, the spleen, pancreas, and liver, among others. So if we have a close look at the endoscope, you have a picture on the top left, we can see that the ultrasound transducer is at the tip, so at the end of the endoscope, which is the element that will provide us with the ultrasound images. It is also has a live endoscopic camera, which allows the clinician to see where the endoscope is going, and also to see the walls of the stomach and esophagus and etc., obviously in real time. The endoscope has also a so-called working channel, as we have heard earlier, which is a channel where small tools like needles can be inserted and used to take tissue samples, for instance, from a tumor in the pancreas. As you can imagine, even if with these two images, the field of view is extremely small, therefore this procedure is technically challenging. There is also a large variability in patient anatomy, And it has a steep learning curve because it requires skills in both endoscopy and image interpretation. So now let's have a look at the information of the different stages or stations that clinicians use for navigation. So there are generally three main stations that are kind of standard starting points to visualize some of the anatomical structures when this is useful when looking at the ultrasound images. So first we have the stomach, from which we can see the liver, the pancreatic body, and also tail, the aorta, and etc. Second, the duodenal bulb, which is the first part of the duodenum, from where we can generally see the gallbladder and the pancreatic head. And finally, the second duodenum, which surrounds the pancreatic head, but can also be used to see other structures such as the aorta. So these are the main anatomical structures that the gastroenterologist will use to navigate the endoscope in combination with the live endoscopic video. However, experienced clinicians might not always follow these steps, and it's important to have this in mind when designing new applications. It is also important to know that these landmarks will only be seen when the transducer is in good contact with the stomach wall. Otherwise, the ultrasound image will not have enough quality to see any of the structures, and we will remain only with the endoscopic video. And EOS is used for different clinical types of examinations, for instance, to see nearby organs that surrounds the stomach, to examine some lesions that might be in the pancreas, and also to do a staging of these lesions if they are cancerous, or to study if the cancer might have spread to other organs nearby. It's also used to investigate other pancreatobiliary diseases. It can also be used to take biopsy, again using fine needle aspiration. It can also be used to deliver some types of therapy in the pancreas or liver, and also to see if there's any stones in the bile duct. And EOS is not to be confused with ERCP, which is another type of procedure, sometimes combined with EOS, but ERCP uses X-rays, and in EOS we only use ultrasound. So the main question for us was, how can we, engineers, help clinicians to perform this very complex and challenging procedure? And I am aware that several people have or are looking into this problem. But next, I will focus and describe the research that we have done at UCL in collaboration with several gastroenterologists as a step towards building a guidance system to assist EOS. So one idea is looking at computer-assisted interventions. So use a computer and novel methods to assist the clinician. And arguably, classic computer-assisted interventions will have the following components or processing steps. So we might have some sort of imaging, which could be preoperative imaging or intraoperative imaging, such as ultrasound. We might have some organ segmentation that we need to do as well, that will help in the procedure. We might need some instrument tracking, calibration between the preoperative images or intraoperative images, and finally, guidance or navigation. So this is not always like this, but generally these are the most common steps or components. And focusing on my experience in the EOS project, next I will describe how we have solved problems with the endoscope tracking, registration, and finally guidance or navigation. And I will start with instrument tracking. Tracking is important because it allows us to track in real time the position of instruments that are used. In our case, is the endoscope. But with EOS, we have a big problem, and is that there's no endoscopes that are commercialized with an integrated tracking. So having a look at the different options we had, we decided to use electromagnetic tracking, mainly because the endoscope is flexible and other systems such as optical tracking wouldn't work. So in electromagnetic tracking systems, we track small sensors that move within a field that is created by a field generator. There is no need to maintain a line of sight between the sensors and the field generator, which makes them very suitable to track instruments inside the body, such as endoscopes or needles. we decided to use the working channel of the endoscope to introduce a sterilized catheter that will contain 7 electromagnetic tracking sensors, which will allow us not only to track the position of the endoscope, but also track its shape. But now the question is, how accurate is electromagnetic tracking when these sensors are placed inside the working channel of the endoscope? And this is important because we know as a fact that nearby objects can affect the accuracy of tracking. In our case, the sensors will be inside the working channel, and the endoscope itself can affect the accuracy. But in addition to this, the endoscope, and in addition to the endoscope, actually, other elements that are in the endoscopy room, such as the C-arm, the patient bed, the ultrasound console, and the clinician itself might affect the accuracy of the tracking. Such that at the end, our electromagnetic field can be slightly distorted. So our first study was to evaluate the accuracy of the tracking system. We use a custom-made machine measure board, we also call it Hummel board, and a structure that would allow us to place this board at 3 different levels, which is shown in the picture number 1. We also created a series of adapters to fix the endoscope and sensors on this board, which is shown in picture number 2. And finally, we find the precision and accuracy by analyzing the positional information of the sensors inside the endoscope at each position on this grid. We also included a simple experiment to evaluate the dynamic errors by fixing the endoscope in a way such that 3 of the sensors would form a triangle. And then we quantified the differences between the edges of this triangle while the endoscope was moving. Finally, we also wanted to know how precise we would be able to estimate the tip of a needle if the sensor was placed at the end of the working channel of the endoscope. And I will not go into details with our results, but the conclusion of this work was that differences were found, but these were not meaningful. The accuracy, therefore, is useful for EUS and is estimated to be around, I think it's below 1 centimeter. So clinicians, they say that if the accuracy is below 1 centimeter, is actually useful to provide navigation. And therefore, this solution has a high potential to support EUS interventions. Next, I will talk about registration, or better said, multimodal image registration, initialization, and how we adapted a classic and well-known registration method to EUS. The main question here we were asking ourselves was how come we could come up with an easy framework to register the ultrasound images with preoperative images such as CT or MRI, which for our clinical application, this task can be very challenging. And the last thing we want is to make this already challenging procedure even more challenging. So just a very brief introduction to registration in case someone is not familiar with this term. So registration is a technique that allows us to align different images or volumes into a single one. We know that multimodal image registration, in our case between ultrasound and CT, can improve navigation because it gives anatomical context. But the problem here is how do we align these 2 images, which are also very different modalities. And after having a look at the different possibilities, we decided to use a classic point-based registration method in where the localization of several anatomical landmarks in EUS would be registered to the localization of the corresponding points in the CT. And the transformation between these 2 coordinate systems would be found, and then we can align the 2 images as well. But with this simple approach, we still had many challenges to solve. For instance, the localization of the landmarks in both ultrasound and CT is very time-consuming, and often is also not possible because the gastroenterologist will be holding the endoscope with both hands, so he cannot go away and find these landmarks in a different computer. In addition to this, we also find problems with tubular structures and the loss of 3D context with the 2D ultrasound images. For instance, if we identify the aorta or the portal vein, it would be extremely difficult to match the exact location that we see in the ultrasound to the CT, because it could be anywhere along the duct, unless we find something like a bifurcation, which we could maybe target a bit better the location. But then the question is, if there is a clinician that is able to find these particular landmarks that are so specific, does the clinician need the 3D navigation anymore? So we had to find a very flexible and easy way to use a method in order to solve this registration problem. And the solution we propose is illustrated here. I want to emphasize that this is not a new registration method. This is a planning method to find the best planes to initialize registration. So the idea is to use CT information only to find positions in the stomach that can be used to initialize registration during EOS. But this must be done in a very flexible manner, such that the clinician does not need to identify these very specific corresponding landmarks, and only that needs to find, for instance, a position and a view. So we start with the extraction of a point cloud that represents the organs and vessels or ducts. Then we also extract the surface of the stomach, illustrated in kind of orange here, which gives us the possible locations where the transducer might be placed during the examination. So we know that the ultrasound transducer, so the endoscope, will remain always inside the stomach. So then we start a Monte Carlo based simulation, in which in each iteration of this simulation, we extract a plausible EOS view from the CT, and we automatically define landmarks considering some localization uncertainty. Then we will register these locations to the point cloud that we have previously extracted using a point-based registration-based method. And finally, we find the difference between the register plane and the ground truth plane in terms of target registration error or TRE. And here, because we have some uncertainty associated with the landmark localization, it means that every time we perform registration, we might have a very different TRE. So for each plane, we perform this task about 1,000 times. So we can also find which is the plane that is more robust. So the plane that will give us the most chance to initialize the registration with a smaller error. So here, if I can run the videos. Yeah. So as a result, we can identify in the procedure planning stage which locations of the stomach are good for initializing registration, and which views we need to find to perform also this registration. So here at the top, you can see an example of these results. The colored surface represents the stomach, and you can also see the two optimal planes that were selected for this particular patient. Another way to interpret these results is by looking only at the colors of the surface of the stomach. If a region is blue, it's likely that a ultrasound plane obtained from that position will give you a better registration result, or what is the same, a registration with a lower error. We can also see in the videos at the bottom that different patients will have different optimal planes. So this is a method that generates a patient-specific optimal planes for registration initialization. Right. So as I said, this was a calculation of the registration error using the CT information only to predict which planes would be good for registration. So one of the questions was, how likely is that in practice we can find these optimal planes when we actually examine a patient with EOS? So we perform a retrospective study with images from a patient to find the corresponding pair of images between CT and ultrasound. And here you can see an example of two of the pairs of the images. So on the left, you have the ultrasound. On the right, you have the corresponding CT images. the color circles represent the different anatomical landmarks that were used for registration for each set of the images. We can see that the images are not exactly the same, but we have deformation, we have some small deformation issues and even a slightly different views. But the results show that despite these differences, there was a high correlation between the predicted theory and the real theory. So results are very encouraging. So as general conclusions of this work, we found that using optimized planes, we can indeed provide a more robust initialization for registration. As expected, there is a time accuracy trade-off when using one or two planes, because two planes have a better initialization, which will provide an error of less than 5 millimeters, but it will also take more time to find two planes than just only one. We also found that both the landmark composition and the specific pose were important, which means that not always the more landmarks we find is the better. It is also very important from which position we see these landmarks. Finally, we believe that this strategy could help reduce the process complexity by relaxing the dependency on landmark selection and localization, and enable a simple way to initialize registration with high accuracy. So next, I will talk about navigation or guidance, which is mainly putting all these concepts together so we can finally assist the clinician to navigate the complexity of the gastrointestinal tract. So we created a demo system that tracks the endoscope with electromagnetic tracking, as I explained earlier. We use a multi-organ segmentation method to extract the anatomically relevant structures that are useful for navigation and guidance. And then we register the ultrasound and CT using also the method that I explained. And finally, we provide navigation in real time. So here you can see how the actual system looks like when used on an abdominal phantom while we're imaging the pancreas, which is the yellow bit, as you can see in the video. So the video is showing the navigation after registration has already been performed using the method explained. We have the ultrasound console, which provides the ultrasound image as they would normally do. And in addition, we'll have a computer that shows this 3D anatomy representation with the endoscopy. The image also shown in the other console, and then the endoscope together with the 3D anatomy in our computer. So the next steps are now to test the full system with real patients, but unfortunately this has been delayed due to the COVID-19 outbreak. And now you might be wondering, this is very nice and classic approach, but what happens with AI? Where does comes AI? And also, what are the current opportunities and challenges in AI when we want to solve some problems in the US? So, as you might be aware as well, AI research is growing exponentially, and there's also very limited examples that are actually deployed in clinical practice. And in the last part of this presentation, I would like to focus on the AI opportunities and challenges, focusing on US only. And for some of the challenges, I might provide you with ideas or solutions, but for some others, I will just not, because it's just still a very much open question. Therefore, I will discuss some personal thoughts and opinions on how to, for instance, obtain expert annotations and contours or landmarks, a little bit more about registration, and also automatic registration recognition. So first, and probably the main challenge, is the difficulty in obtaining large, well-curated data sets with enough quality to be representative and useful that allows a robust clinical validation of any AI method. It happens that ultrasound is often not stored or included in medical reports, and if it is, it's often just a single image. So the studies here we can run are very limited. And this is a problem for AI, which we need a large number of images. Also, because it's highly operator dependent, standardization and acquisition protocols for EOS might help developing AI solutions. As I said earlier, experienced clinicians might not always follow the different stations. So I think if we want to perhaps develop some AI approaches, we might need to have a bit more standard in the image acquisition. So to have an idea of how difficult this task is, I want to show you this example. This was during an EOS procedure. I recorded about 30,000 frames with a duration of total duration of 20 minutes. And here I'm just showing you a selection of some of these frames. After the procedure, with a very experienced clinician, we went through the whole video, trying to identify some of the anatomical landmarks that we saw. So to my surprise, there were only 2 sets of frames in which the clinician was very confident or confident enough to identify more than one landmark, which is the 2 frames that you can see with the red border. So also as a reference, it took more time to identify these landmarks than the whole procedure itself. First, because we had to go through the video, and then we had to see if the landmarks were the ones that he thought that were we were seeing. So one of the problems in the identification of this landmark was the loss of 3D context. So when they do the procedure, they know more or less where the endoscope is located, so they have a better idea on what the structures they might be looking at. If they are not confident, they will move the endoscope a little bit, go back to the original position, and then be in a good position to be confident to name the landmarks. So one of the conclusions is that we need novel ways and tools to identify anatomical structures that are of interest and that might be useful for AI methods. And maybe incorporating these with reconstruction and then registration could be an easy way to do this identification of landmarks in larger studies, and then build a database that AI can use. Another problem is the variability in expert annotations, and which is magnified with EOS. If you are familiar with ultrasound, you might have noticed that in this image, there are not very well defined boundaries between organs when compared to other ultrasound-based procedures, such as transrectal ultrasound for prostate or fetal ultrasound or cardiac ultrasound. For instance, on the right, this is an example of possible contours of a prostate in a transrectal ultrasound image. We can see that different operators will provide slightly different contours, so we have some variability here, which is expected. Going back to our initial example, you can now see the annotations that an experienced clinician provided. So if we focus on the pancreatic body, which is at the top of the image, and we ask another clinicians to provide the contour of the pancreatic body, we might get something like this, which is shown now in blue and also in yellow. So as you can see, EOS seems to be more subjective and also arguably might have more variability associated with the interpretation of the ultrasound image, which might make the validation more difficult as well. This is a big challenge for AI-based method, as in AI we often need to define and provide large amount of well-defined label images. So another question is how to use AI to solve the registration problem. And at UCL, we have developed DeepReg, which is a deep learning toolkit for medical image registration. Here you have the website in case you are interested and want to have a look. And I think solutions like this might be very relevant to enable the registration of 3D ultrasound volumes, which could be acquired using electromagnetic tracking, and then registered to CT without the need to have to define the landmarks manually and use a point-based registration method. And also, it could be done automatically during the procedure. As we have seen, this is an extremely task and very time-consuming to do it in real time. And finally, and focusing perhaps on more clinical aspects and very similar to what we have seen from Dr. Ms. here at the beginning, I believe AI will play an important role in US by automatically performing tumor recognition. I think that's very important, for instance, in pancreatic cancer. It will also be, in my opinion, be very useful for recognizing some of the main anatomical landmarks. For instance, the pancreatic duct, which is an anatomy that is very relevant when we want to visualize the pancreas from head to tail. It's anatomy that we can follow, and sometimes it's difficult because it can be confused with the bile duct. So I think tools like this could be very useful for assisting the clinician when it comes to guidance and navigation as well. And yeah, Leslie, I just want to thank you for listening, and I'm happy to answer any questions that you might have. Thank you.
Thank you very much, Dr. Bonmati, and you're all invited to send any questions you might have again to any of us. Esther, so given the challenges here in the interpretation of US and the need, even as you showed of that experienced clinician, his need to close the loop during the procedure itself in order to interpret his own images, where do you think sort of the most useful path lies here? Does the real clear pathway to enhancing US with AI computer vision go through developing and implementing new hardware like EM tracking, giving us 3D context? Do you think that's a requirement here to really be of benefit? Or do you feel that there are things that can be done even like with the existing hardware capabilities, which are two-dimensional, things maybe such as classification tasks like tumor recognition, or maybe identifying some specific subset of the anatomy that is possible in this way? Just your thoughts on that.
Yes, I think the two options are actually possible, and perhaps the best option would be a combination of both. So we know that understanding what you see on the ultrasound image is very important, but also an important factor for navigation is to have this 3D representation. So perhaps a combination of some perhaps more classical methods in where we track the endoscope with the tracking and we provide the 3D view, but then also at the same time we have a separate window that is doing anatomy recognition, is doing tumor detection, that enhances all the ultrasound image information that we have. I think that would be the best solution I can think of.
Okay, yeah, so for all you guys out in the industry that I see here in our attendee list, yeah, we're waiting for you. Okay, we're not waiting, no. I mean, at least you're definitely not waiting for anybody. Thank you very much for sharing your work and really showing how you guys are laying the foundations for this technology, and really zeroing in on the most important questions that should be asked in this field. We expect to hold our next RSIP webinar in a couple months' time. So we'll keep everybody posted about that. And this webinar is being recorded, and it will be posted shortly on the web, so you can share with your colleagues and anybody else who missed us today. And thanks again to our lecturer and to our guest speaker. And until next time, have a great day, and hope we can meet soon in some other context, whether virtual or in person or both. Thank you very much.
Thank you.
Take care. Bye.